So we're gonna start with tricuspid regurg now. Tricuspid regurg JVP waveform. So first of all, in order to understand what JVP waveform is, we need to look at this diagram. So JVP stands for jugular venous pressure waveform. So this pressure curve denotes the pressure in the atria. So that is the number one thing that you guys need to keep in mind in order to make sense out of this. So even though the labeling here is ventricular diastole, ventricular systole, but the pressure curve denotes the pressure in the atria, not in the ventricles. So when they say ventricular systole, that means that the pressure here denotes the filling of the atria, the passive filling of the atria. And when it denotes ventricular diastole, which is relaxation of the ventricles, this indicates the blood being pumped from the atria to the ventricles. It can be passive during the start, and then when the atria contract, it becomes active. So basically, when they say ventricular systole, it means the atria are going through diastole, and when they say ventricular diastole, the atria are going through systole, that is, the atria are contracting and pushing blood from atria to the ventricles. So once this concept is down, we can look towards the labeling here, that is X, Y, V, and A. So the two most important things here are the X descent and the Y descent. So what does the X descent and the Y descent indicate? I'm gonna tell everything of what they indicate and in what pathology is this X and Y gonna change. So let's start with the X descent. So as it states here, it's ventricular systole. So when the ventricles start contracting, this bulge, that is the C wave, indicates that the tricuspid valve closes, and due to the pressure of the ventricles, it bulges back into the atria, causing a transient increase in the pressure in the atria. So this increase in pressure is denoted by the C wave, and then the pressure suddenly drops. Why does the pressure suddenly drop? Because the atria are contracted, and as the ventricular contraction starts, the atria start relaxing. So the X wave, the X descent denotes the atrial relaxation. And after that, why does the pressure start rising? Because now the blood from the vena cava, superior and inferior vena cava, starts filling the atria, so the pressure starts rising again. So once again, what does the C denote? C wave denotes the bulging of the tricuspid at the start of the ventricular systole. When the ventricles contract, the tricuspid valve bulges back into the atria, causing a transient increase in pressure. After that, the atria relax, that is the X descent, and after that, once the atria start filling with blood again, there is a rise in pressure. So this is X descent, followed by X descent represents the atrial relaxation. This represents the atrial filling. We can also say passive atrial filling by the vena cava. So the pressure rises, and at this point the pressure becomes maximal. So at this point, ventricular diastole starts, that is, the ventricles start relaxing. And once the ventricles start relaxing at the V point, the pressure in the atria becomes so much that the tricuspid valves open and the blood starts passively flowing. Mind the word passive. So this is the Y descent. So what does the Y descent denote? It represents the passive emptying of the atria into the ventricles. The blood starts to leak from the atria into the ventricles as the tricuspid valve opens. So C represents the closure of the tricuspid valve. The V represents the opening of the tricuspid valve. The Y descent represents the passive emptying of the blood from the atria into the ventricles. And as the blood passively empties, the pressure in the atria falls. But you see, the pressure starts rising again. Why? Because the atria start contracting at this point. So the Y descent denotes the passive atrial emptying into the ventricles, and this rise in pressure curve, which is this, represents the active atrial emptying due to the atrial contraction into the ventricles. And the A wave, the A peak, basically represents the peak pressure in the atria during their peak contraction. And once the peak contraction is achieved, the ventricles once the peak contraction is achieved at the A peak, the pressure starts to fall again as the atria start to relax again, and as soon as the ventricles contract, there's a bulge of pressure again due to the tricuspid valve closure. So this is how you explain the JVP waveform, and the most important thing is it denotes the pressure in the atria, not in the ventricles. So ventricle systole is atrial diastole, and the ventricular diastole is the atrial systole. So let's sum it up again. The bulging of the tricuspid valve here, and then the atria start relaxing. Why does X descent? Then the pressure in the atria rises again because the blood is passively filling it. And at this point, at the V wave, the atria start to passively empty into the ventricles because it is ventricular diastole, and that is represented by the Y wave, which represents the passive atrial emptying. Then the pressure rises again, which denotes the active atrial contraction, and the active atrial contraction causes a peak pressure rise that is at A point, after which the atria start relaxing again and the ventricles contract and the bulge again happens. So what happens in tricuspid rigors? Now we're gonna discuss the pathologies again and again, one by one, and how they cause a change in the JVP waveform. So the question is gonna come in a way that they're gonna show you altered JVP waveform and ask you what is the pathology going on, whether it's tricuspid regurg, whether it's cardiac tamponade, whether it is AV block, complete AV block. So seeing the JVP waveform, you must be able to identify what the pathology is. So when it comes to tricuspid regurg, I'm gonna explain all the changes that are gonna happen here. So basically, when there is a tricuspid regurg, you're gonna get an absent X descent. What does it mean when they say absent X descent? It means that there is no descent. You can also say that there is a flattening of X descent or an absent X descent and a very prominent V wave. So what's gonna happen? I'm just gonna give you the crux of what's happening here. That is because of tricuspid regurg, the pressure in the atria during ventricular diastole is gonna be elevated all around. It's simple as that. Why? Because when the ventricles contract, the pressure is not contained in just in the ventricles. The blood regurges back into the atria, and the overall pressure during the ventricular systole in the atria, that is during ventricular diastole, is going to be atrial diastole is going to be increased. So this is ventricular systole here. That is the contraction of the ventricles, that denotes the atrial diastole, relaxing of the atria. So normally the atria relax, then they start filling with blood. But in regurg, tricuspid regurg, the blood comes back and the pressure all around stays high in the atria. So basically, if they give you a JVP waveform where in ventricular systole, the pressure is all around greater than the baseline. There is no X descent. The atria are relaxing, the pressure should fall. The pressure does not fall because the blood regurges back in the atria, and because there is more blood regurging back into the atria when the atria start filling passively from the superior and inferior vena cava, the pressure is even more greater in the V wave. That is a very prominent V wave and an absent X descent. So basically, tricuspid regurg, you're gonna get an all-round increase in the pressure in the atria. There would be no dip seen in the pressure in the atria while the atria are relaxing. So basically, what I mean to say is during atrial relaxation, the pressure should fall, but it does not, because the tricuspid regurg causes the regurg of blood back into the atria. So tricuspid regurg, a very prominent V wave and a flattening of X descent or absent of X descent. So this is tricuspid regurg. So I come to tricuspid stenosis now. What's going to happen in tricuspid stenosis? The pressure, you're going to see a very prominent A wave and a flattening of Y descent. Why? So this one is also really simple. You don't have to get into the complexities of that, because there is tricuspid stenosis. So let me ask you a question. When is the pressure in the atria gonna be more than usual? What is tricuspid stenosis gonna cause? Tricuspid stenosis is gonna prevent the blood from going into the ventricles while the atria are contracting. So what part of the JVP represents the contraction of the atria? That is ventricular diastole part of the JVP denotes that the atria are contracting and the ventricles are dilating, ventricles are relaxing. So all the parts that fall into the category of where the atria should be contracting, the pressure goes up. Like ventricular diastole, normally the Y descent represents the passive atrial emptying followed by the contraction of the atria, which causes the A wave. So the tricuspid valve is stenosed, it's not letting the blood out into the ventricles. So overall pressure here in the ventricular diastole region would be great. This is the Y descent. It's gonna flatten. Why? Because usually there is a passive blood flow from the atria into the ventricles, but the tricuspid is not letting the blood flow. The pressure rises during the Y descent, so we get a flattening of Y descent. You can also say absent Y descent because, yeah, Y descent is flattened. And when the atria do contract, the pressure rises way above beyond the normal because there is more pressure in the atria required to push the blood through the tricuspid stenosis. So let's just do a summary again. Tricuspid regurg, what's going to happen? All the parts of the JVP waveform that fall under the atrial relaxation part would get the regurg of the blood flow, and the wave overall, the JVP waveform in that part would increase. This part, absent Y descent, very, very prominent V wave. But when it comes to tricuspid stenosis, all the parts of the JVP waveform that fall under the part where the atria are contracting, that is the ventricular diastole parts, they would go up. So you just need to remember all the parts that fall into the relaxation part of the atria and the contraction part of the atria, and you can make sense of what's happening. Other than that, you guys do need to remember and memorize it. Flattening of Y descent, very, very prominent A waves. That means it's tricuspid stenosis. Flattening of X descent and very, very prominent V wave, that denotes tricuspid regurg. So this is here. I've also written a really good summary here as well. Tricuspid regurg, prominent V wave. Peak filled atria before the opening of tricuspid valve are more filled than usual due to the regurg. Obviously, X descent flattening, regurgitant blood flow results in improper atrial relaxation. I've written all the reasons behind all the explanations. AFib, what's gonna happen in AFib? As you guys know, what happens in AFib, there is no uniform contraction of the atria. So all the parts of the JVP waveform where the atria are contracting would become abnormal. That is the ventricular diastole parts that denote that the atria are contracting would become abnormal. And what are you gonna see there? Absent A waves, no peak atrial contraction seen. So the A wave denotes the peak atrial contraction, as you know, Y descent passive atrial emptying, and then the atria start contracting, because in AFib there is no uniform contraction, there would be no A wave present. So that is how you make sense of AFib. Tricuspid stenosis, I told you all the parts of the JVP waveform where the atria are contracting, the pressure would be greater. That is all the ventricular diastole parts. Flattening of Y and very, very prominent A waves. So when the pressure rises in a certain chamber, you get the descents flatten and the waves become prominent. This is the X descent, so you will say the X descent flattens. This is the Y descent, you say the Y descent flattens, and these are the waves A and V. You say they become prominent. So this is how you make sense of these findings. Tamponade, flattened Y descent. Why does the Y descent flatten? First of all, Y descent represents the passive atrial emptying. What happens? Tamponade, the ventricles are not able to accommodate the extra blood coming from the atria. So the pressure, when the atria try to push the blood passively into the ventricles, they do not accommodate, and the pressure in the atria rises. So you would also get Y descent flattening when it comes to tamponade. Atria unable to passively fill ventricles since tamponade restricts ventricular filling. Complete AV dissociation. Cannon A waves. What are cannon A waves? A waves. Why are the A waves produced in the first place? They represent the peak atrial contraction. What happens in AV block? The atria and ventricles beat randomly without any coordination. So what are cannon A waves? Cannon A waves are very, very prominent A waves that happen when the atria and ventricles contract at the same time. What's going to happen when they contract at the same times? When the atria contract, the pressure is denoted by the A wave, and if the ventricles contract at the same time, the pressure peaks way above the limit, because the atria are contracting and the ventricles are contracting at the same time, and the blood is not being able to push into the ventricles, so the pressure in the atria skyrockets. That is termed as cannon A waves. So we've discussed everything here, and you need to make sense of everything that we've discussed here if they give you a JVP waveform. So let's give it a read as well. Tricuspid regurgitation causes a prominent V wave and an absent X descent due to elevation of right atrial pressure throughout ventricular systole. Ventricular systole, represents atrial relaxation or atrial diastole. Overall increase in pressure during the atrial relaxation phase because the blood flows back into the atria. Transvenous lead placement through the tricuspid valve can cause severe tricuspid regurg due to direct valve leaflet damage or inadequate leaflet approximation. So, all this information here is from a scenario where they give that the patient had placement of a cardioverter defibrillator or a pacemaker, and after that, they give you a JVP waveform, something like this. And they say that the patient's heart is failing, and this is the JVP waveform they give. So, what is the reason behind this happening? The reason is tricuspid regurg following the placement of a cardiac pacemaker. Why does this happen? Because in order for the placement of of the pacemaker, you use a transvenous lead, where the lead goes from the tricuspid valve in order to place the pacemaker or the defibrillator, and during that placement you might damage the tricuspid valve, leading to the tricuspid regurg. So they say this complication should be suspected in patients presenting with right sided heart failure following implantable pacemaker. So the scenario is going to be like the patient got a pacemaker installed, and after that the patient had signs of JVP, jugular venous pressure. JVP was raised, and they might give you this waveform that confirms that it is tricuspid regurg, and they say that the patient does not have any pulmonary edema. That further makes you sure that it is the problem with the right side of the heart, not the left side of the heart, because when there's a problem with the left side of the heart, you get pulmonary edema. They might also give you pulmonary capillary wedge pressure to be normal as well, further confirming that is a right heart problem. And they will give you this as well, confirming that it is a tricuspid regurg. And they might also give you the location of the murmur, that would be at the APT tricuspid region. That would further confirm that it is tricuspid regurg, and then they're gonna ask you the reason behind it, and the reason is the damage to the tricuspid valve during the placement of the pacemaker. Chronic severe tricuspid regurg typically presents with right-sided heart failure. Patients can have a distended jugular veins, pulsatile and tender hepatomegaly, all the signs of right heart failure, abdominal distension, ascites, that is the cardiac ascites due to backflow of the pressure into the liver, and lower extremity edema as well. Cardiac examination typically reveals right ventricular heave and a hollow systolic murmur, best heard at the left sternal border, at the basically at the T region, at the tricuspid region, and the quality of the murmur would be hollow systolic, that is constant throughout the systole. When the ventricles are contracting, there's a constant noise due to the backflow of the blood from the tricuspid valves. The murmur intensifies with maneuvers that increase right ventricular preload, for example deep inspiration, leg raises. So why does the murmur increase with increased preload? With increased preload, more blood flows from the atria to the ventricles, and when the ventricles contract, there's more backflow. So that is why the murmur intensifies. The diagnosis of tricuspid regurg, if suspected, would be done through an echocardiogram. So one more high yield point of information here is that tricuspid regurg is usually secondary to enlargement of the right ventricular cavity. And what happens when the right ventricular cavity enlarges? The annulus where the tricuspid valves are adherent to, the annulus dilates, and thus the valves are not being able to properly approximate. So if this is the annulus, it dilates and the valves become incompetent during their closure. So it's a similar presentation to the left heart failure. When the left heart is failing, the ventricles dilate, and as a result of which there is mitral valve annulus dilation that also causes mitral regurg. The similar phenomena also happens here with the right heart. So they say right ventricular enlargement causes tricuspid annular dilation as well as increased tension of the chordae tendineae, similar to that of the left ventricle enlargement, resulting in mitral regurg due to annular dilation. So what can you decipher from this paragraph? The important thing is, that if a patient has pulmonary hypertension that is leading to cor pulmonale, what happens in cor pulmonale? The right side of the heart starts to fail. So what it means to say that cor pulmonale, let me write it down. So I've summarized all the important scenarios that pertain to this paragraph. So cor pulmonale due to pulmonary hypertension. If a patient has pulmonary hypertension and develops cor pulmonale, which is failure of the right heart, right ventricular failure and dilation would eventually result. And that dilation of the right heart would cause the development of secondary tricuspid regurg. This is what this paragraph tries to say. That tricuspid regurg is due to the dilation of the annulus. For another scenario, left ventricular MI, and that results in progressive left heart failure. That would result in left ventricular dilation. That can also lead to secondary mitral regurg. Chronic uncontrolled hypertension would result in left ventricular dilation and left heart failure. Other signs would also be present like pulmonary edema and the person not being able to lie flat and sleep and causing orthopnea and difficulty breathing if he tries to sleep flat, and other signs like pitting edema if the failure goes to the right heart as well, and other signs. But if you see a murmur of mitral regurg, that is most probably secondary to left heart failure and LV dilation, and the left ventricular dilation would result in mitral annulus enlargement, so the valves would become incompetent, they would not approximate properly, and then we will have mitral regurg. So tricuspid stenosis, I already explained the JVP waveform. What's going to happen? All the parts where the atria is contracting, the pressure goes above. All the parts that fall under ventricular diastole. Y descent represents the passive atrial emptying, and this represents the contraction of the atria, and A wave represents the peak contraction. Everything goes up. Y descent flattening, A waves become really prominent. So JVP demonstrates a flattened Y descent prominent A waves due to obstructed right ventricular filling. JVP, yeah, it's the same. So you can read this paragraph as well. It tries to summarize how you can understand the JVP waveform, but I explained everything written here as well. So these are all the problems that result in a different alteration in the JVP waveform. You need to memorize what is gonna happen in tricuspid regurg, AFib, tricuspid stenosis, tamponade, complete AV dissociation. It should be on your fingertips. So let's start with the CVS contraindications to pregnancy. So the complications that are really high risk when it comes to pregnancy are if a patient has stenosis of any kind, mitral stenosis, aortic stenosis, and it is causing symptoms, it's an absolute contraindication to pregnancy. Aortic regurg is not a contraindication. Mitral regurg is also not a contraindication. The stenosis is a more bigger problem. Now the question arises, why does the stenosis is a bigger problem than regurg? Because during pregnancy, you get hypervolemia. During pregnancy, there's volume expansion and there is overall increase in the blood volume because the fetus needs the nutrients and the blood needs to be pumped to the placenta as well. So that results in a hyperdynamic circulation during pregnancy. So stenosis of any kind prevents the adequate increase in the cardiac output that the patient requires. So it causes a lot of strain on the heart relative to the regurg. Regurg is not restricting blood flow to the body, but stenosis does. So any sort of symptomatic stenosis, it's an absolute contraindication to pregnancy. Any sort of heart failure that shows that the patient might not be able to keep up with the demands of increased circulation, like heart failure with the left ventricular ejection fraction less than 30. If the ejection fraction is less than 30, the patient is barely keeping the requirements of his own body adequate. So if the fetus comes into play and that requires extra circulation, the heart won't be able to keep up with it. So pulmonary arterial hypertension. So this is also stenosis of a kind. Why? Because it is restricting blood flow. Regurg is not a form of restriction, but stenosis is. So pulmonary arterial hypertension restricts the blood flow from the right ventricle to the left ventricle, right heart to the left heart. So it is also a contraindication. Bicuspid aortic valve with ascending aorta enlargement greater than 50 mm. So this is also a contraindication. Aortic enlargement greater than 50 mm is the highlight of this point. Why? Because that shows that the aorta has an aneurysm, and during a hyperdynamic circulation there is a risk of rupture. So this is also contraindication. So to summarize, a stenosis or obstruction of the blood flow of any kind, mitral stenosis, aortic stenosis, and obstruction can, the pulmonary arterial hypertension is also under this category, because it also restricting blood pumping from the right heart to the left heart, and left ventricular ejection fraction less than 30, which means the heart is not capable enough to support a fetus. So, mitral stenosis usually occurs due to rheumatic heart disease. Initially, there is regurg. After that, after 10 years, the patient develops stenosis, and is a common cause of pregnancy related complications that include decompensated heart failure. The patient may be in compensated heart failure, but when the patient becomes pregnant and the load on the heart increases, that results in decompensation of the heart failure with elevated left atrial pressure and pulmonary edema. So if a patient had a history of, so this is a really important question as well. Patient had a history of rheumatic heart disease, and the patient now becomes pregnant and then presents with heart failure at the 3rd or 4th month of pregnancy. Why do I say 3rd or 4th month? Because this is really important. You need to differentiate it from peripartum cardiomyopathy. This is not peripartum cardiomyopathy. They will also give you that murmur is also recognized, and the murmur would that be of mitral stenosis, and it would be in nature. You might hear a opening snap, and the murmur would be hollow diastolic in nature. So you know it's the murmur of mitral stenosis, and the patient, after becoming pregnant at the 3rd or 4th month of pregnancy, develops heart failure. You know that the heart failure is due to decompensated heart failure, and that is due to mitral stenosis. Increased risk of left atrial atheroembolism due to stagnant left atrial blood flow and the underlying hypercoagulable state of pregnancy as well. So there are a lot of other factors that make it even more dangerous. So if the heart decompensates, the atria enlarges, the body is already in a state of hypercoagulable state, so that can result in formation of clots in the dilated left atria. Symptomatic mitral stenosis is among the highest risk cardiac conditions during pregnancy and is a contraindication to taking pregnancy to term. Therefore, valve repair should be done prior to getting pregnant whenever possible. Medical management is often appropriate for relatively low risk valvular diseases, mitral regurg, aortic regurg during pregnancy. I told you the most dangerous one are the stenosis or anything that obstructs the blood flow from the heart, like pulmonary hypertension, and if the heart failure with left ventricular ejection fraction less than 30, you know the heart is not capable. So let's start with abdominal aortic aneurysms. So before we move on to abdominal aortic aneurysms, let's just discuss another important question. Patient with history of rheumatic heart disease, murmur of mitral stenosis is heard, gets pregnant. And after the patient gets pregnant, at the 2nd or 3rd month, develops pulmonary edema, signs of heart failure, and ECG shows AFib. What has happened here? So what has happened here is basically the patient had a history of mitral heart disease, rheumatic heart disease, and initially might have developed mitral regurg, then developed mitral stenosis, and the patient was asymptomatic. And the patient didn't know about it. The patient got pregnant, and what happened after that? Since the patient had mitral stenosis, there was atrial dilation going on in the background. But when the patient became pregnant and the patient went under hypervolemia due to volume expansion during pregnancy, the atrial dilation became more worse, and the patient went into AFib. And after the patient went into AFib, so the asymptomatic mitral stenosis became symptomatic. Why? Because in mitral stenosis, the atrial contraction is really important. In a normally, otherwise, in a normal person, if a normal person develops AFib, they are asymptomatic. But if a patient with mitral stenosis develops AFib, they become symptomatic. Why? Because the atrial kick or the atrial contraction is crucial to pumping blood from the atria into the ventricles, because there is already obstruction to the flow from the atria to the ventricles due to the stenosed mitral valve. So when the patient developed AFib, that is when the patient started going into heart failure and developed pulmonary edema, because now the already stenosed mitral valve, there is no blood flow across it because the concentric or uniform atrial contraction is lost. That is termed as loss of atrial kick. So what I'm going to write here is loss of atrial kick resulting in uh, resulting in the asymptomatic mitral stenosis becoming symptomatic. So, loss of atrial kick causing asymptomatic mitral stenosis to become symptomatic. So, abdominal aortic aneurysms. Let's give it a read here. This is one of a scenario. This is one of the scenarios where a patient that has undergone repair of the abdominal aortic aneurysm develops bloody diarrhea and abdominal pain after the procedure, 1 or 2 or might even be 3 days. And they ask what is the reason behind the bloody diarrhea or the just the reason behind the patient's symptoms. So there are two differentials here. One is C. diff and the other one is abdominal bowel ischemia. So the thing that you need to know about this is that bowel ischemia is a really known complication of abdominal aortic aneurysm repair, because during repair, when you clamp the abdominal aortic, there is a transient cutoff of the blood supply to the bowel, and that can result in ischemia. And as a result of ischemia, the patient will develop abdominal pain and bloody diarrhea after the procedure, 1 or 2 days after the procedure. The patient can also have fever and leukocytosis. Why is this not C. diff? Because C. diff causes voluminous watery diarrhea, not bloody diarrhea, and it is also not common after 4 to 5 days. It is also not common after just 1 or 2 days of antibiotic use. It takes at least 5 to 7 days of antibiotic use to present with C. diff diarrhea. So we'll give it a read. Bowel ischemia is a non-complication of abdominal aortic aneurysm repair. It results from inadequate colonic collateral arterial perfusion to the left and sigmoid colon. Usually the left and the sigmoid colon are affected after loss of inferior mesenteric artery during aortic graft placement. Patients present with abdominal pain, bloody diarrhea, fever, leukocytosis may also be present. The adverse effect can be minimized by checking sigmoid colon perfusion following placement of aortic graft. So you need to take care during operation and after operation as well that the colonic perfusion is adequate and has not been obstructed. So this is a really important question where they'll give that a patient underwent abdominal aortic aneurysm repair, and after the procedure, 1 to 2 days after the procedure, developed abdominal pain and bloody diarrhea. And the options you might get uh, all the things that produce bloody diarrhea, like you might also get intussusception, you might get other things as well, and C. diff diarrhea might also be present because the patient is on antibiotics. So you need to be able to differentiate all this. C. diff is most common cause of nosocomial diarrhea. Pseudomembranous colitis occurs following antibiotic treatment and is most commonly causes of voluminous watery diarrhea, not bloody diarrhea. In addition to abdominal pain and fever, these are overlapping, but the voluminous watery diarrhea, not the bloody diarrhea, helps differentiate. Bloody diarrhea is rare. It is also uncommon to develop C. diff infection so early on. So, screening. I'm also gonna make lectures about screening and screening and vaccination, but we'll also cover during the system-wise study as well. So, abdominal aortic aneurysm screening is done in any man that reaches 65 and has smoked ever in his life. And the modality of screening is not gonna be CT or MRI or anything like. It's just going to be simple plain or duplex ultrasound no, of the abdominal aorta that will be able to detect the aneurysm. So, just to summarize, any man who is at the age of 65 and has ever smoked needs abdominal aortic screening one time. So, ultrasound, one time abdominal ultrasound in men aged 65 to 75 who have ever smoked. It has high sensitivity, the ultrasound it is low cost. So, screening for abdominal aortic ultrasound may be beneficial for men aged who have not smoked but have other significant risk factors. So, basically, just need to remember any man between the age of 65 and 75, any man who reaches the age of 65 and has ever smoked, they'll just give you this scenario where the man is 66 years old, has a smoking history, but quit 20 years ago, and they're gonna ask you what is the next best step in screening. So you're gonna choose abdominal ultrasound for abdominal aortic aneurysm. So CTM and RF also have both high sensitivity but are more expensive. So we go for ultrasound when it comes to screening. So, evaluation of suspected unstable aortic aneurysm. What is unstable abdominal aortic aneurysm? Unstable means that it is causing symptoms and there's a risk of impending rupture. That is what we call unstable. So, unstable abdominal aortic aneurysm is going to present with pain, abdominal pain, and flank ecchymosis, and the patient will most probably have a pulsatile mass in the abdomen. So, what are we gonna do? I have just rephrased it really, really well. We only obtain, so there's a confusion whether we'll obtain a CT or an ultrasound. We don't obtain anything if the patient has a known history, that if the patient was screened at the age of 66 and was found to have an abdominal aortic aneurysm, and after 10 years that patient presents with symptoms like pulsatile mass, abdominal pain, or flank ecchymosis, you don't do anything. You just go for an emergent repair. You just take that patient for a repair. uh, So, to rephrase, we only obtain abdominal CT if the patient is stable. Otherwise, we do an abdominal ultrasound while preparing for surgical repair. So, we only obtain an abdominal CT if the patient is stable. Otherwise, that is, if the patient is not stable, we do an abdominal ultrasound while we take the patient for surgical repair. And we can even skip the abdominal ultrasound if we already know that the patient had a history of abdominal aortic aneurysm. That is, when the screening was done like 2, 3, 4, or 10 years ago, we found that the patient had an abdominal ultrasound. So let me just present you with some scenarios. The patient was screened at the age of 66, was found to have an abdominal aortic aneurysm, and now the patient presents at the age of 72 with abdominal pain and flank ecchymosis. What are you going to do? You go for an emergent repair. The patient is at the age of 72, had a smoking history, and presents with abdominal pain, pulsatile mass, and flank ecchymosis. And when you do take the patient's blood pressure, it is 80 over 60. What are you going to do? You take the patient for emergent abdominal aortic repair, and while you're taking him, you do an abdominal ultrasound, because the patient in this case, we don't know if he has an abdominal aortic ultrasound, but we do know that the symptoms align and the patient is hemodynamically unstable. So you take the patient for emergent abdominal emergent repair, and while you're taking him, you do an ultrasound. So if the patient is the patient is 72 years old, has a history of abdominal aortic ultrasound, was screened at the age of 66 and was found to not have anything, and now presents with abdominal pain, pulsatile mass, and flank ecchymosis, and the blood pressure is 100 over 80, what are you going to do? That means the patient is stable, the symptoms align with unstable abdominal aortic aneurysm, and we don't know whether the patient had a history of abdominal aortic aneurysm. So we do a CT before we go for the emergent repair. So this rephrasing is really well. We obtain the CT only if the patient is stable. Otherwise, we just take the patient for the repair, and while we're taking the patient for repair, we can do the abdominal ultrasound. And if the patient has a known history, you don't do anything, just take him for the repair. Any symptomatic patient with a known history of AA and hemodynamic instability, Wherever you come with hemodynamic instability, you just take for the emergent repair. It is considered to have rupture and should undergo emergent repair. And since the patient has a known history of abdominal aortic aneurysm, we're not going to even do the abdominal ultrasound while we take the patient for repair because the patient has a known history. However, in patients with hemodynamic instability and signs and symptoms consistent with abdominal aortic aneurysm, but without a known history, because the patient is unstable, you take the patient for the repair, and while you're doing it, you perform a bedside ultrasound. So this covers everything here. Amylase and lipase are elevated in acute pancreatitis, severe cases of which may be complicated by retroperitoneal hemorrhage, causing a presentation with flank ecchymosis and hemodynamic instability. However, hemorrhagic conversion of pancreatitis is rare, and the absence of fever, nausea, vomiting make the diagnosis in this patient less likely. So do not confuse the hemodynamic instability of abdominal aortic unstable abdominal aortic aneurysm with pancreatitis that has undergone hemorrhagic conversion, because the patient might present with phlegm ecchymosis, that is the gray Turner sign, and abdominal pain or epigastric pain, and you might feel that it is and the patient might have a history of smoking, so you might feel that it is maybe an unstable abdominal aortic aneurysm. But you might feel that the patient might also, in addition to that, might have acute pancreatitis. But remember that acute pancreatitis presents with fever, leukocytosis, and other signs as well. So I've written down an important question here that's going to help you. Patient with smoking history, epigastric pain, flank ecchymosis, age 69. So the patient has a age 69, has a smoking history. So the patient might have abdominal aortic aneurysm, normal temperature, leukocytosis. Oh, so when it comes to unstable abdominal aortic aneurysm, you will not see leukocytosis. BP is 120/80 and the patient is hemodynamically stable. What is the most likely diagnosis? Most likely diagnosis is acute pancreatitis. So when is the diagnosis in this scenario gonna be abdominal aortic aneurysm that is unstable? It's gonna be if the patient has no leukocytosis, that is a normal CBC, and the patient has a blood pressure of 80 or 60. It's gonna be considered hemodynamically unstable, which is not likely in acute pancreatitis, so then it's gonna be abdominal aortic aneurysm. What if the BP remains 120/80, that is stable, and there is no leukocytosis? Even then, it's gonna be abdominal aortic aneurysm, because leukocytosis is a hallmark of acute pancreatitis. It is not seen in abdominal aortic aneurysm, unstable abdominal aortic aneurysm. So this is how small things, if interchanged, uh, make the diagnosis different. So what is the high yield finding? What is the next best step if you suspect acute pancreatitis? It's gonna be CT scan of the abdomen. What is the next best step if you find that it is unstable abdominal aortic aneurysm and the patient is stable? It's gonna be abdominal CT. What is the next best step if the patient is unstable and you suspect abdominal aortic aneurysm? It would be, depending on the history, if there's a known history, surgical repair. If there is no known history, you do the surgical repair while you also perform a bedside ultrasonography. So abdominal aortic aneurysm, advanced stage smoking, that is the most high yield cause. Mostly asymptomatic. If it becomes symptomatic, it is called unstable abdominal aortic aneurysm. Dull abdominal back pain, distal embolization, rupture, sudden severe abdominal pain, back pain, shock, that is hemodynamic instability, flank or umbilical hematoma. So elective repair is done if there is the size of the aneurysm is greater than 5.5 centimeter. This is a really high yield point. They'll give you the size and ask you for, the patient would be not symptomatic, just came for screening, and the size would be 6.5 centimeter. They're gonna ask you what is the next best step. It would be elective repair. They're gonna also give you another scenario where the patient is asymptomatic, comes and you do a screening and the size is 5.5 centimeter, and they're gonna ask you what is the next best step. Observe the patient. So this is what you do for the unstable type, urgent repair for symptomatic, and hemodynamically stable patients. I told you about the CT and abdominal ultrasound thing. So basically, you need to remember the size for elective repair. If you do a screening and the size comes out, you need to know whether you're going to just observe or you're going to go for elective repairs. Active smoking is the strongest modifiable risk factor for AA development. Smoking cessation is considered the best intervention to minimize abdominal aortic aneurysm progression because of this relation between one time. So, as I told you about the screening, a, a, a guy who is 65 or above and has ever smoked, you do the screening with one time ultrasonography. Does not matter if the patient left smoking 20 years ago, you still do it. Pain is the most common initial manifestation and can vary according to the aneurysm location. This is really high yield. Proximal aneurysms tend to present with upper abdominal, flank, or back pain, whereas distal aneurysms present with lower abdominal or groin pain. Other clues to the diagnosis are pulsatile abdominal mass. This is really high yield. Prevertebral aortic calcification on plain X-ray, consistent with extensive atherosclerosis, which would indicate that the patient will likely also have abdominal aortic aneurysm because it is associated with atherosclerosis. That is why smoking is the biggest cause. In symptomatic patients who are hemodynamically unstable, the diagnosis should be confirmed with abdominal CT if the patient is not a known case of abdominal aortic aneurysm. If he is, then you just go for the repair. Patients typically have few symptoms until AAA markedly expands or ruptures. So that's why it is asymptomatic initially and it becomes unstable when the size becomes really large, precipitating abdominal or flank pain. So the high yield patient presentation would be like the patient presents with a history of dull abdominal pain that is constant in nature, and the patient also on observation has a pulsatile mass in the abdomen. This is the most high yield presentation for stable abdominal aortic aneurysm. It's just a nagging abdominal pain and you can palpate a pulsatile mass as well. Less common presentations include distal ischemia due to embolization of the thrombus because because the aneurysm is a dilation, so there is not adequate or fluid blood flow and there's blood stasis in the aneurysm that results in clot formation, and that clot can go further downstream and cause distal ischemia and high output cardiac failure resulting from erosion. So if there's a aortocaval fistula, what is an aortocaval fistula? When the aneurysm forms, the wall weakens, and if the wall starts to erode and then connects with the vena cava, inferior vena cava, that is just adjacent to the abdominal aortic aneurysm, that can result in the formation of a AV fistula that can precipitate the high output cardiac failure because of a very rapidly increased preload. AAA rupture usually occurs posteriorly into the retroperitoneum, which can delay the onset of hemodynamic instability. So, what I want you guys to keep in mind is the fact that it is not necessary that if a patient has abdominal aortic aneurysm rupture, he just dies at the spot, because usually the rupture is in the posterior peritoneum. The blood collection is contained, and since the blood collection is contained, the symptoms of hemodynamic instability can be a little bit delayed. So usually what the logic says is that if the aorta just ruptures, the person should instantly die of hemodynamic instability and blood loss. But this is not the scenario. Even after rupture, the patient might survive some time. So you need to keep that in mind as well. A rupture does not mean instant death. However, rupture may occur anteriorly and direct leakage into peritoneum and rapid onset of hemodynamic instability and shock. So you need to be aware of both the scenarios. Typical patient presentation: age 68, history of smoking, dull abdominal pain radiating to the back, sounds like dissection. Examination shows a pulsatile mass in the abdomen. That is where the entire diagnosis shifts, because you see a pulsatile mass in the abdomen. The pain is radiating to the back, but if it is acute pancreatitis, you might also see fever and leukocytosis, and that won't be present here. So that's how we differentiate. Acute pyelonephritis, fever, leukocytosis, flank pain. Yeah, it also sounds a little bit similar. when it to abdominal aortic aneurysm, rupture when it comes to the location of the pain, but there would be no hemodynamic instability here. And you would, in addition, you will get leukocytosis and fever. Commonly presents with flank pain and hemodynamic instability may occur due to sepsis. However, you will find leukocytosis and increase in body temperature. This patient's lack of fever and dysuria makes diagnosis less likely. So that's how you differentiate. Just don't worry about the pain, location of the pain. Also see whether the patient has fever, leukocytosis, dysuria, or instability. Acute renal infarction also presents with flank pain, but the patient would also, infarction would not result in hemodynamic instability. However, it is accompanied by hypertension. Why does the acute renal infarction result in hypertension? Because there is renal ischemia, so renin-angiotensin-aldosterone system upregulates that, as a result of which you get hypertension due to renin secretion. Fever is also common. So that's how you differentiate these findings of abdominal aortic aneurysm, acute pyelonephritis, acute renal infarction, and acute pancreatitis. Let me write this down of the differentials when it comes to abdominal aortic aneurysm. So you guys need to get a really good grip about these four: unstable abdominal aortic aneurysm, acute pancreatitis, acute pyelonephritis, and renal infarction. You should know how to differentiate between these four. So another scenario: 65-year-old male, 2 to 3 days history of severe chest pain, dyspnea, visible pulsation above manubrium, tracheal deviation, murmur in the second intercostal space on the right. So, what is the answer? The male is 65, 2 to 3 days of severe chest pain, dyspnea, visible pulsation above the manubrium. This is the high yield giveaway, tracheal deviation, a murmur in the second intercostal space, AP, on the right. That is the A region. So, you have a murmur at the aortic region, and you have visible pulsation above the manubrium sterni. So this makes me think that there is dilation of the ascending aorta resulting in aortic regurg. So that is the answer most probably. So let's see a USMLE answer. Aortic aneurysm. So ascending aortic aneurysm or dilation that would disrupt the aortic valve resulting in regurg. What we say when we discuss the murmurs of the aortic regurg, I also aortic root dilation. I also talked about that. So that would result in aortic regurg. So this is another scenario: dysphagia and hoarseness caused by dilated cardiac structure. That is, left atrial dilation causes dysphagia. Which structure is dilated? Left atrium. So left atrium dilation results in compression of the recurrent laryngeal nerve, causing dysphagia and hoarseness. So you also need to be wary of this fact. It's not always damage to the recurrent laryngeal nerve. It can also be due to dilation.